ado, I'm going to let Radha take it away.
Great, thanks so much, Dr. Yu. It's been a pleasure to be back, and a really great experience being on the internal medicine ultrasound elective. So I'm looking forward to giving this presentation and hearing your feedback as well. So without further delay, I'll get started. So the topic today is lung ultrasound, specifically interstitial syndrome, what I'm calling variations on a theme, bringing me back to my piano playing days, but that's what came to mind when I was looking through this topic. So to give you a brief outline of what we'll be covering, we'll start with the utility of lung ultrasound, and then speak more in detail about sonographic interstitial syndrome, speaking also about lung ultrasound protocols and acquisition technique. And then we'll go through some cases of different types of interstitial syndrome, after which I'll provide some conclusions and thoughts about future direction. With that, I will turn my camera off for now, just to hopefully optimize our connection. So in terms of the utility of lung ultrasound, as all of you are aware, lung diseases are among the most common pathological conditions worldwide, and this includes pneumonia, interstitial lung diseases, including IPF, COPD. We also have pulmonary edema, which, although often from congestive heart failure, ends up presenting as a lung issue and a major health issue at that. So accurate diagnosis and monitoring of lung diseases are concerns of a global scale. Standard imaging techniques which we use, including X-ray and CT, are obviously associated with radiation exposure. And additionally, CT can be expensive. It may be unavailable or inaccessible at the site that you're working at, and it's also unavailable at the bedside. So lung ultrasound makes for a safer, portable, cost-effective alternative. Now, moving on specifically to sonographic interstitial syndrome, sometimes that's used interchangeably with the term alveolar-interstitial syndrome, but it's essentially a recognizable pattern characterized by the appearance of several acoustic artifacts known as B-lines or comet tails. Now, I think everyone here is probably quite familiar coming to these focus rounds with sort of distinguishing between A-lines in a healthy lung and the B-line artifacts that are described in interstitial syndrome, so I won't spend too much time on that. Sonographic interstitial syndrome is defined by the International Consensus Conference on Lung Ultrasound as 2 or more regions bilaterally with 3 or more B-lines in a longitudinal plane between 2 ribs. And there's correlation between these artifacts and the increase in cardiogenic and non-cardiogenic edema, interstitial pneumonia, ILDs, lung contusions, etc. Now, in terms of the lung ultrasound protocols for interstitial syndrome, as many of you are probably familiar with, one of the most well-known protocols is the Blue protocol, which was devised for critically ill patients. The benefit is that it's fast, ideally taking less than 3 minutes, with inspection of 3 points per side: upper anterior, lower anterior, and the PLAPS point. In the Blue protocol, only the anterolateral B-lines are considered. Posterior changes are not as relevant because they may be due to gravity alone. But while this may be sufficient for identifying acute cardiogenic pulmonary edema or ARDS in critically ill patients, it's not thought to be adequate when it comes to other causes of interstitial syndrome, such as interstitial lung disease. So there are other protocols. The International Consensus Conference in 2012 defined an 8-zone sonographic technique, 4 zones per side in the anterolateral chest wall as a better assessment for interstitial syndrome. However, that too may be insufficient, as many forms of ILD start by affecting the lung bases predominantly, and so a lot of the characteristic pleural pulmonary findings may reside there. So in essence, there are so many different protocols available, everything from 4-zone to 14-zone, and some have even proposed using a 28 rib segment scanning method, including posterior scanning, to improve diagnostic yield for identifying ILD-related interstitial syndrome. There hasn't been much standardization with regards to which protocol is used, but interestingly enough, in our current era of COVID-19, there have been more calls For standardization, the usefulness of lung ultrasound has been recognized when it comes to management of patients with COVID, whether that's diagnosis, monitoring, or follow-up. And so a group in Italy has called for all researchers to try and standardize their lung acquisition protocols, and have recommended a 14-zone approach where you are scanning 3 posterior, 2 lateral, and 2 anterior zones per side, ideally for 10 seconds each. But they do have the caveat that if posterior access is difficult, then to at least try for a partial view of the posterior basal area, standing at landmark 7, which would be kind of lateral, the costoangle or Plapp's point. In terms of acquisition technique, I won't spend too much time on this, but for those who are still relatively new to POCUS like myself, I think some of the main take-home points is they recommend the use of a convex or linear transducer according to the patient's body size. Now, of course, our convex probes here are quite big in terms of their profile, and so they're not so convenient for lung ultrasound in terms of getting into the intercostal spaces. They recommend using a single focal point modality and setting the focal point on the pleural line. This is something I didn't know how to do or wasn't aware to do prior to this rotation, but essentially by moving the focus point to the pleural line, that's where the beam has the smallest width and is set to best respond to smallest details. They also make recommendations with regards to controlling gain. And then for the more experienced practitioner, there are recommendations with regards to things like mechanical index, saturation phenomena, cosmetic filters, etc. Speaking with Dr. Yu, my understanding is that cosmetic filters are found in many abdominal exam presets, but with our newer ultrasound machines, these are turned off, or we have the ability to turn them off in most lung and thoracic presets. But the downside of that, the downside of turning off the filters is that it can reduce the quality of pleural effusion images. So as I've mentioned, there is significant correlation between these artifacts and causes of interstitial syndrome like edema, interstitial pneumonias, ILD, lung contusion, etc. In fact, one study showed that B-lines correlated with 93% accuracy in terms of radiographic changes noted on X-ray, or with full accuracy in terms of radiographic changes noted on CT. So the consensus statement is that a positive lung ultrasound is superior to X-ray when it comes to ruling in significant interstitial syndrome, and a negative lung ultrasound is superior for ruling out significant interstitial syndrome. However, what I'd like to focus on now is that sonographic interstitial syndrome is not representative of a single uniform entity. So the question becomes, how can we differentiate between the many causes of interstitial syndrome? To illustrate some of the key learning points for this, I've decided to go through 4 cases to highlight different causes of interstitial syndrome and ways to differentiate between them. So to get started, the first case is that of a 93-year-old female who was admitted with shortness of breath and hypoxia. Her past medical history is significant for atrial fibrillation, rheumatoid arthritis. At the time of assessment, she was relatively stable, but requiring supplemental oxygen, 2 liters by nasal prongs. And her chest X-ray had shown some interstitial edema as well as bibasal or atelectasis, but no pleural effusions. She also has a previous echocardiogram that showed an ejection fraction of 55 to 60%, mild mitral stenosis, moderate aortic stenosis, mild or aortic regurgitation. So I've opted not to share as many clips for this case because I think cardiogenic pulmonary edema, which is what we're illustrating here, is something that most are probably familiar with, as that's kind of the classic case of interstitial syndrome that we are taught. What I'd like to highlight is that this appearance that I've shown here is similar to what we obtained with scanning most or all zones bilaterally, particularly in the dependent areas. There was this similar appearance in all the zones of diffuse, homogeneous B-lines without any spared areas, because the even nature of fluid accumulation results in that diffuse pattern without any sparing. There was also a thin pleural line without significant irregularity. And as you can see, the B lines are moving. We have good lung sliding, and the B lines are moving in accordance with the lung sliding and effacing the A lines as they do so. So that's fairly typical of hydrostatic or cardiogenic pulmonary edema. What I did want to spend a little bit of time talking about was this concept of septal syndrome. So the secondary pulmonary lobule, which is what I've shown a picture of here, is the functional unit of the lung. It's a cluster of up to 30 acini, which is supplied by a common distal pulmonary artery and bronchiole. Those clustered acini are bound by interstitial fibrous septa or interlobular septa, which is continuous with other interstitial components of the lung. And interlobular septa are thicker and more numerous along the lung periphery and subpleural regions. When you get an increase in microvascular hydrostatic pressure, there's transudation of protein-poor fluid from the microvessels into the interstitial space. In the pre-alveolar stages of cardiogenic pulmonary edema, the interstitial fluid accumulates in a centripetal manner from the periphery to the pulmonary hilum, expanding the lymphatic vessels and consequently the secondary or interlobular septa. What that causes pathologically is you can see the arrows denote these thickened interlobular septae. And on ultrasound, what they've seen is that this appears as septal syndrome, where there are these discrete B lines separated by a distance that's congruent with the distance between the interlobular septa, approximately 7 millimeters. There have been studies that have shown septal syndrome does appear in cases of cardiogenic pulmonary edema, but not in cases of non-cardiogenic alveolar interstitial syndrome. So essentially our conclusion for this patient after performing her lung ultrasound is that she had bilateral interstitial syndrome, diffuse but more prominent in the dependent zones with tiny or small bilateral pleural effusions. And we suggested this may be on the basis of pulmonary venous congestion given her known stenotic mitral and aortic valves. And with that said, we recommended continuing with diuresis. Moving on to the second case. This is a case of a 76-year-old gentleman who was admitted with a 2-week history of cough, decreased oral intake, and feeling generally unwell. Probably a presentation that many of us are seeing frequently these days. Past medical history was significant for non-ischemic cardiomyopathy. He has a CRTD. He also has atrial fibrillation, history of stroke, PE, CKD. At the time of assessment, he was a bit hypotensive with a blood pressure of 96/59, but otherwise stable, and oxygen saturation was 98% on room air. His chest X-ray appeared fairly unremarkable with no acute parenchymal processes or pleural effusions seen. And he has a previous echocardiogram that showed reduced ejection fraction of 30 to 35% with mild mitral regurgitation and mild aortic stenosis. So looking at these clips here on the right and left anterior zones, this was fairly unremarkable with an A-line predominant pattern. However, moving to the lateral zones, what we saw is that there were focal B lines in the right lateral zone. And as you can see, these B lines are a bit more uneven, and there may even be some spared areas of near normal lung. And that's because inflammation in a situation such as this can cause a heterogeneous leakage of protein-rich fluid at the alveolar capillary membrane, generating edema, but it's more randomly distributed. The other thing I wanted to highlight here is that you can see pleural irregularities with heterogeneous pleural edema. So as you can see, there's a bit more of a fragmented pleural line seen where the B lines are arising from. And then it may be a bit harder if you're not sort of familiar with it, but there are areas of subpleural consolidation seen as well, which I'm going to speak about in a bit more detail. So subpleural consolidation are subpleural hypoechoic areas with ragged margins that are representative of areas of consolidated lung. They can be distinguished from a loculated effusion because there's craniocaudal movement of those areas in synchronization with the lung sliding during each breath. And subpleural consolidation is more suggestive of an infectious or inflammatory etiology. So again, to review, in this case, we saw that there was focal interstitial syndrome with some pleural irregularities and subpleural consolidation. All of those changes are similar to what can distinguish ARDS from cardiogenic pulmonary edema. I didn't see any patients with ARDS during this rotation, but there were very similar features that you would see. So for this patient, we ultimately concluded that he had patchy bilateral alveolar interstitial syndrome with pleural irregularities that would be in keeping with multifocal pulmonary infection. And given his history, we asked whether this could be a resolving viral infection. Initially, there had been concern that he could have pulmonary venous congestion, but based on this lung ultrasound, we said that that was not a current issue and that they could continue IV fluids as indicated or tolerated. I apologize, I believe I've got my sides incorrect here. It should say right greater than left alveolar interstitial syndrome. Does anyone have any questions so far before I move on to the next case?
I guess to the audience, feel free to leave comments or questions in the chat as well. I'll monitor it.
Great. Okay, well, I'll keep going. This next case is a 65-year-old female who was admitted with hypoxia with a question of possible interstitial lung disease versus a first presentation of a CHF exacerbation. Her past medical history is significant for obesity, hypertension, diabetes, and chronic kidney disease. At the time of assessment, she was stable except perhaps mildly hypertensive, but requiring 4 liters by nasal prongs to maintain an oxygen saturation of 93%. She had a CT thorax, which was completed in hospital. I'll take a couple of minutes just to read through this, but essentially there were diffuse bilateral areas of subpleural reticulation and architectural distortion, especially in the left upper lobe, patchy areas of peribronchovascular and subpleural ground glass opacity, again, more so in the upper lobes, some increased interstitial markings in the mid to upper lungs, and a few areas of ground glass opacity or ground glass consolidation, especially in the left apex. So the radiologist's impression was that this suggests an underlying interstitial lung disease, which has progressed from a previous chest x-ray, and the radiologist was not in favor of this being pulmonary edema. She's also had an echocardiogram from that same hospitalization, which showed preserved ejection fraction, no diastolic dysfunction, and normal RV size and function as well, and no hemodynamically significant valvular disease. So fairly unremarkable. So this first image is evidence of B-lines or interstitial syndrome at the left upper anterior zone. And what we're just trying to illustrate here is that in her case, it was apically predominant interstitial syndrome. What I'd also like to show is that it was a non-homogeneous distribution with spared areas of normal parenchyma. Sort of see that on both the previous. Sorry, let me just play that. On this image as well, you can see that there are some spared areas. And then moving more distally, she actually had an A-line predominant pattern, which is not typical for someone with cardiogenic pulmonary edema. So again, you can see here, even at the base, there was no pleural effusion and no B-lines even at the base there. The other thing that I wanted to highlight here is that she did have significant pleural irregularities, maybe not the clearest image, but what you can see is that's quite a blurred, fragmented, irregular pleural line. So what I would like to sort of spend a bit of time right now is talking about how ultrasound for ILD can correlate with CT findings. In early stages of ILD, even before thickening of the subpleural interlobular septa, you can have ground glass changes seen on your high-resolution CT thorax. Ultrasound examination of those areas will give numerous B-lines with a more narrow distance between them, approximately 3 millimeters. When you develop more well-established fibrosis, you get a reticular pattern or honeycombing on your high-res CT thorax, which then corresponds to a widened appearance of the B-lines on lung ultrasound. And that's associated with the subpleural interlobular septa being thickened from deposition of collagen and fibrous tissue. So for this patient, her CT had commented on subpleural ground glass changes. And I think that's probably in keeping with the fairly close together B-lines that we were seeing on her ultrasound, although we didn't measure them specifically. This is better illustrated in this image here, though, where on the first or on the top two images, you can see ground glass opacity on CT, which corresponds to B-lines that are closer together on ultrasound. And in the bottom two images, there's subpleural reticulation with honeycombing, which corresponds to B-lines that are a bit more discrete or wide apart. Something else that's emerging in terms of how we can assess for ILD using lung ultrasound is perhaps looking for a change in vertical artifacts with change in transducer frequency. In a study from 2021, Buddha et al. Looked at two groups, patients with ILD secondary to systemic sclerosis or scleroderma, as well as patients with pulmonary edema due to CHF. And they used the convex transducer to evaluate vertical artifacts at two different frequencies, 2 megahertz and 6 megahertz, and then the linear transducer as well to evaluate for pleural line abnormalities. What they noticed is that changing the ultrasound frequency from 2 to 6 led to a shortening or even disappearance of vertical artifacts, with some of them converting to Z lines or even A lines. And this phenomena was more characteristic for pulmonary fibrosis than edema. So seen in 61% of examined areas in patients with pulmonary fibrosis, compared to only 24% of examined areas for patients with pulmonary edema. And that was statistically significant. They also saw that patients with ILD were more likely to have pleural line abnormalities, such as irregular, fragmented, blurred, or thickened pleural lines more than 2 millimeters, which is consistent with previous research as well. In terms of why the change in frequency can lead to a conversion in vertical artifacts, it's quite a detailed explanation that they provided, but ultimately it seems that there are changes in the shape of the acoustic trap which can cause these B-lines, and those differences can lead to this conversion between B-line to Z-line or A-line. So for this patient, reviewing the changes that she had sort of apically predominant B-lines with spared areas, more heterogeneous, and also had pleural irregularities. So with that, we concluded that she had bilateral apically predominant alveolar-interstitial syndrome in keeping with the distribution of her CT thorax findings. And given the persistence of these findings despite diuresis, and given the dependent zones were less effective, we favored ILD over pulmonary venous congestion. We also commented that the pleural irregularities were concerning for active inflammation or ILD. Now moving on to the final case for today. This is a 77-year-old female who was admitted with shortness of breath and hypoxia. She also had 2 episodes of emesis on the day of her presentation, so potentially some concern of aspiration. Her past medical history is significant for lung adenocarcinoma with chemoradiation in 2014, as well as radiation to a right upper lobe nodule in 2017, and she also has COPD. At the time we assessed her, she was a bit hypotensive and was satting 96% on 4 liters by nasal prongs. Her chest x-ray showed chronic post-radiation fibrotic changes in the right lung, as well as an extensive consolidative opacity in the left lower lobe in keeping with the pneumonia. There was also some rounded opacities seen in the left upper lobe, which could correspond with one seen on a CT in 2020. So I thought this was a great example to show because as you can see here, this patient has essentially decreased or almost absent lung sliding, because in fibrosis, traction of the fibrotic parenchymal tissue and the pleura can contribute to absence of lung sliding. You can also get pleural irregularities, and as you see here, she's got a very thickened, irregular pleural line. Also referring back to our last case where we talked about how with established fibrosis, you may get more widely separated B lines. I think that's consistent with what we're seeing in this patient in her right lung as well. So throughout the right lungs are very almost fixed B lines with significant pleural irregularity and decreased or absent lung sliding. I wanted to contrast this with her left lung, which is much more sort of normal looking in appearance. Perhaps still some pleural irregularity there, but an A-line predominant pattern anteriorly in the upper zone. A little bit lower down, however, she does have interstitial syndrome on the left as well, but you can see there that there's clear lung sliding, even though there is still some pleural irregularity. And then at the bases, there's a significant difference in terms of the curtaining that we're seeing on the left, which we couldn't see on the right. So the main point here is that the inflammatory process in conditions such as ILD or fibrosis can impede normal sliding between the visceral and parietal pleura, which can manifest as reduced or absent lung sliding. For this patient, we concluded that she had fixed B lines on the right side, likely chronic or related to post-radiation fibrotic changes, but fairly diffuse unilateral alveolar-interstitial syndrome on the left, which could be infectious or inflammatory in etiology, and we recommended continuing with antibiotics. So to summarize some of the main points from those cases, ways that we can distinguish between different causes of interstitial syndrome. We can start with whether it's diffuse or focal, with diffuse interstitial syndrome being seen in etiologies such as pulmonary edema of various causes, interstitial pneumonia or pneumonitis, and diffuse parenchymal lung disease, including pulmonary fibrosis. More focal interstitial syndrome or localized interstitial syndrome may be seen again in pneumonia if it's more lobar, atelectasis, pulmonary contusions, pulmonary infarction, sometimes with pleural disease or neoplasia. Main features to contrast other causes to cardiogenic pulmonary edema. So for acute respiratory distress syndrome, which we didn't see, although we saw sort of a more infectious seeming case, ways to distinguish ARDS would be anterior subpleural consolidation. You may also get absence or reduction of lung sliding, some spared areas of normal parenchyma, pleural line abnormalities, and non-homogeneous distribution of B lines. Other features that are more indicative of pulmonary fibrosis or diffuse parenchymal lung disease would again be pleural line abnormalities, as we discussed, subpleural abnormalities, and then B lines in a non-homogeneous distribution, and specifically correlating with the CT distribution or CT signs of fibrosis. Now, I just wanted to say a quick word on pleural effusions. As you know, there is some question as to whether or not pleural effusions are helpful in terms of differentiating between cardiogenic or non-cardiogenic causes of interstitial syndrome. The data is fairly heterogeneous in terms of the diagnostic value, without clear consensus as to whether or not they are helpful in terms of distinguishing the underlying etiology. So for now, I think there is probably equivocal or unreliable diagnostic value in terms of pleural effusions. So in conclusion, hopefully what you have learned or seen illustrated by our cases today is that sonographic interstitial syndrome is not a single uniform entity. It requires a nuanced approach and interpretation to formulate an accurate diagnosis and management recommendations. In terms of the utility of lung ultrasound, though, I think the fact that we are starting to figure out these nuances is extremely helpful, and it will improve our inpatient as well as outpatient management. And I think as someone in general internal medicine, that's a particular area of interest to me, is how we can use this more often in an ambulatory setting. And there has been some research done in that direction with regards to how we can look at pulmonary congestion before discharge in patients with CHF to predict rehospitalization, or how we can evaluate outpatients with heart failure to predict their risk of decompensation. So many, many uses for lung ultrasound for a general internist, and I think it's a continuously growing area of research and application as well. Certainly, I think lung ultrasound will have even more utility outside of emergency and critical care if we can ensure it's reliable, reproducible, and if ultimately quantitative techniques are developed. And with development of quantitative techniques, some of the advantages may be that we can standardize lung evaluation across centers, which can be used to guide and inform treatment, and hopefully also improve our ability to follow the progress of a disease or monitor response. For example, if someone's on antifibrotics for IPF, to monitor their response to treatment. So I think it's a very exciting area with lots of room for growth and huge benefit in terms of our practice in internal medicine. So with that, I would be happy to take any questions, and thank you again for your time and for joining our rounds today.
Thank you, Radha. That was a great presentation. I'd like to open the floor up for any questions or comments.
I have a question. First of all, yeah, that was awesome. Good talk. I'm curious, like, my general understanding of this is that when you have more of an inflammatory infectious picture, you get this 3 millimeter distance, versus where you have something that's more established, or like edema, you get the 7 millimeter. Have you come across anything that says that in these patients that do have active inflammation, if you were to treat them with steroids or to treat them with antibiotics, like what is the timing to consider a repeat ultrasound? And do you see that kind of transition from the one pattern to the other with treatment with steroids in someone with ILD? Did you see anything about that? Or
it's a really good question. I didn't come across that information myself. I don't know if Dr. Yu has, maybe he'd be able to comment further. I mean, I think what I was mostly seeing was sort of them distinguishing that 7 millimeter pattern in terms of it being present in cardiogenic pulmonary edema or absent in non-cardiogenic. I don't think there was as much comment about the 3 millimeter distance in terms of like ARDS. However, it was mentioned in terms of fibrosis with the early versus late changes of fibrosis. But in terms of how that may resolve or change with treatment, I didn't personally come across any information, and potentially it's still early in the field of exploring that for them to have done those studies. But I think it's a really good question that hopefully one day we'll have an answer to.
Yeah, because similarly, like we've had a few patients, like we scan them in the unit and they have finished a course of antibiotics and we see dynamic air bronchograms. So now what do you do with that? Are you like using that information to say that there potentially still is that infection there, we should prolong the course of antibiotics? Or is it something similar to like a chest x-ray where it just takes time to go away? And I think it might be less like a chest x-ray, considering that you can actively see a consolidation go away with recruitment measures. Like you can see that consolidation turn into aerated lung. So that's why we're like, we sometimes get stuck here. We debate amongst us in the group here. We're like, what do we do when we see dynamic air bronchograms on somebody who's finished antibiotics? I don't know if anybody has an answer to that, or.
Yeah, I haven't personally come across that literature myself, especially with regards to features of consolidation, how they, or the time course to resolution. But I agree with you. We've seen patients with pneumonia who are, as they're treated, their ultrasounds show rapid improvement. So I don't know how we can apply that in terms of our clinical decision making. Mike, did you have some thoughts on that?
I have a question, if there are no other thoughts on that. In your experience here, in terms of scanning protocols for lung ultrasound. You touched on that at the beginning of your talk. What has your experience been like in different types of scanning protocols, the ease of use in different more extensive protocols versus the more simplified Brew protocol? Just what was your experience with all of that?
Yeah, lots of, I guess, variation. I think part of it is just in terms of the patient status, like if they're more bed bound or having limited mobility. In those cases, I find I'm often still doing their scan supine or semi-supine, and with more restrictive access to the posterior zones, I've typically done, I'd say, more of like a modified 12 zone approach where I try and do sort of anterior upper lower, lateral upper lower, and then a PLAPS point, but don't necessarily get the posterior upper zone. So a little bit more extensive than the ICC 8 zone approach, but still not doing as much posterior scanning as what they've recommended in terms of the standardization with COVID-19. When patients are able to sit up at the bedside, I have tried scanning a bit more extensively in terms of posterior, probably doing those 3 zones, similar to what they had suggested in the 14 zone approach with COVID-19. And I think where I found that particularly helpful was for that patient with what we're presuming to be ILD, because scanning posteriorly really sort of made it very clear that she had apical predominant disease, and then really none to little in the more dependent areas. And so I think there is definitely benefit of that, and I can see why they're recommending adding in more of that posterior approach for ILD specifically. So I think a lot of it comes down to patient ability in terms of the protocol that you use. And in an outpatient setting, I'd imagine, and also in an inpatient, you know, if I wasn't on an ultrasound rotation where I've got the benefit of time, I think sometimes using a modified or shorter protocol is also just time effective or more efficient, that we don't always have time to do a full 14 zone protocol for every patient in clinic, for example. So I think probably trying to standardize a slightly more efficient protocol that kind of sits somewhere between the 14 zone and the Blue protocol would be the most efficient and effective clinically.
Yeah, I'll just hop on to that, Radha, because I mean, I basically just walk around and scan patients on the ward with my Lumify, and definitely doing a full, whatever you want to call it, 14 zone approach is not practical, because I'm probably going to scan 5 patients that are hypoxic on the wards a day. But what I also don't advocate for is just doing 4 points on each side, or the Blue protocol or whatnot, and then calling it a day. I think that having kind of a screening, so if you want to use kind of 4 zones on one side of a supine patient, and my general approach is, if there's no abnormalities in any of those spots, then I'm usually pretty happy to say that it's likely that there's not a significant parenchymal abnormality that's contributing right now. But as soon as you find something, as soon as you have a consolidation, as soon as you have some B lines, then that's when I take time. And that's when I start to try and figure out what's going on. So I think having kind of your screen where I can go, like 1, 2, 3, 4, it's absolutely like normal, then, and the patient's hypoxic, well, is it reactive airways? Is it a PE? Is it something else? And I can do that, as I'm talking to the patients, 2-3 minutes tops. But then as soon as you find some pathology, then you need to spend time looking, because if I find some B lines here, well, maybe there is something apical, and maybe I do need to go more posterior to the apex. Maybe I do need to compare sides in a bit more detail. So I think it's about kind of having, and standardization is great for research, but also just not practical, I think. And, a patient that can sit up for you really quickly, and you can do a quick scan down their posterior, like rib spaces, like boom, 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 all A lines, that's great. Not many of our C2 patients are if they could stand, usually they're at home. So so being able to like scan quickly in the supine patient is also very practical.
Yeah,
I totally agree with Mike. I actually had a patient this morning that like the lung to chest X-ray was not impressive, and but she's on like 10 liters, and so I just kind of went to scanner, and but I was like, let me just go look posterior, and I found a bunch of gunk posteriorly higher up, like a lot of subpleural consolidations, and so kind of but I think you have to take the clinical picture, a clinical story, and then kind of your scan, and then kind of explore, I guess, while trying to be efficient, because ultimately when you're scanning it, you're trying to find an answer for yourself, and so sometimes that may maybe doing 8 zones, sometimes it's doing 4 zones, sometimes it's just doing 1 zone, right? You're like, oh, they have a massive pleural effusion. Okay, got it. So I think it really depends on the scenario, but I agree with Mike.
I see Dr. Naidu
thanks both for your input.
has her hand raised.
Hi, excellent talk, Radha. It
Thank
was
you.
very refreshing. I know we usually forget lung ultrasound so fast if you don't keep doing it. So Jeff, Michael, and Radha, just a question. Have you all seen any decrease in the use of X-ray as follow-ups overall when you guys are available as a team to do POCUS follow-up and provide with clinical information? So have you seen a decrease in the use of X-ray, or are they still doing X-rays in spite of including ICUs? I think I want to know from both places.
I start and then I'll pass it on to Dr. Yu. Just in terms of my experience over the last several weeks, I certainly think it does decrease the number of X-rays that are being obtained, because I think in terms of when there's questions about, has the pulmonary edema resolved? Can we stop Lasix? Or is this still the pneumonia, or is there a new process now contributing to these increased oxygen requirements? When the teams are aware that they have us in place and we have the ability to do these scans, I'm seeing that there often is not a chest X-ray ordered concurrently. So they're not, putting the two side by side, but they're relying on the impression from the ultrasound in many cases. So I think from my personal experience, it does decrease the number of chest X-rays. If it hasn't already been studied here, I'm sure that'd make for an interesting study or QI project, but Dr. You can comment further.
I can comment about CTU sort of anecdotally and also semi-quantitatively. So anecdotally, when I'm on CTU and I have a POCUS resident, or if I'm doing the POCUS myself, absolutely, right? Absolutely, I'm reducing the number of X-rays or scans that are needed. For example, I often find residents wanting to order lateral decubitus films for pleural effusion. That's just completely unnecessary in the era of ultrasound. And even in my practice, at least post-thoracentesis, I typically don't get a post-procedural X-ray, because with ultrasound, I have greater sensitivity in ruling out pneumothorax, and I even have direct quantification of the pleural effusion that's remaining. Sometimes I will get an X-ray if it is required for other specialties to follow, to compare. But if I'm looking after the patient and I have a pre and post ultrasound, that's really enough, and I don't need extra X-rays to look at that. And then semi-quantitatively, we've had rotations where the rotator had looked at whether the ultrasound had changed overall management. And obviously the sample size was small. It was only a single scanner, but there was some data indicating, yeah, the number of X-rays that the team would have proposed had decreased significantly because of the presence of the POCUS rotator. And I don't know, Mike, if you have any comments about in the ICU.
Yeah, and I can jump on, and I'm sure Mel will be able to agree or disagree with this, because she's finishing up her critical care ultrasound training right now too, and especially in the ICU, like the portable chest X-rays there are oftentimes useless, because with patients that are completely supine, and I'm sure you know, Renuka, like all of them, a big pleural effusion could look identical to a big consolidation on a AP portable. So the critical care ultrasound fellowship, the team that, you know, Mel and Drew and all them are on right now, there's rotators at both sites. Every morning, the ICU teams request scans, and it's usually for the patients who are, you know, having difficulty weaning from the vent, have, you know, increased ventilatory requirements, and trying to figure out, like, is that atelectasis? You know, do you need to kind of increase your PEEP? Do you need to do some recruitment? Is there, you know, pulmonary edema? Is there something else going on? Could there be a pneumothorax? And so, like, a diagnostic chest X-ray almost doesn't exist in our ICUs anymore, and that's obviously not the case on the ward. But as Jeff mentioned, like, depending on who's on, myself, Jeff, and Zane primarily, probably at this point, you know, I would say that there's probably good evidence that we order less chest X-rays, because if I know that someone's hypoxic, I'm just going to go around with my team and get them to scan them.
Yeah, and to that I would also add, I think the decision point of when to get a CT, I think also it's not just like, oh, we don't know what's going on, get a CT. It's like, oh, we see a complex effusion here. This does not look right. Get a CT that looks at some sort of, this is weird. This is odd. And then chances are, more often we sort of pick up stuff that we have a high pretest probability being like, this CT is going to be quite abnormal. So I find, I don't know, Mike and Jeff, if you guys have had that experience too, but I find that it definitely, there's a more sort of good reason for me to go ahead and get that CT for a patient. Yeah.
Great. Perfect.
It's interesting too, just to Mike's point, because when I've been on community rotations where, you know, maybe POCUS is not used as widely, there's been, you know, daily chest X-rays for the COVID patients in ICU. And does it really change our management day to day? Probably not. But I think, you know, ultrasound on a more regular basis, where as indicated, would definitely probably actually add more to the clinical decision making.
Yeah, ultrasound, I mean, when I'm sure, you know, Zane is doing this on Team 4 right now, but COVID has a specific look, it has a specific pattern. And so oftentimes when these patients are getting worse, it's go look for something else. Like, go look for that big pleural effusion that needs to be tapped. Go look for that big consolidated lung or significant atelectasis that might suggest, you know, a superimposed bacterial infection. Or, you know, I recall a patient, this was like a year ago, got transferred from a peripheral center for COVID query needing like ECMO. And we scanned her and she just had crazy atelectasis in both lungs. And we just had to like crank the PEEP up to like 20 to keep her lungs inflated. And then she like left the ICU. So oftentimes it's not, sometimes it's not, you know, looking for pathology. You know, you're going to find pathology in all these COVID patients, but it's like ruling out other things, like what else could be contributing. And when you can rule out some of those other things, you can be confident to continue on your current treatment path, knowing that you're unlikely to be missing something else.
Are there any other questions or comments from the group? So thank you once again, Radha, for such an excellent presentation and allowing us to have such a great discussion around lung ultrasound and the current events with COVID-19. And so I guess with that, we're about time, and I'm going to end the session now. Thank you, everybody.
Thanks a lot, Radha. Great talk.
Thanks, everyone.
Thank you.
Yeah, nice talk. Thanks.
Thank you. Good luck with your next chapter.
Yeah, thank you. Take care.